Hello, everyone. In this podcast, we will be discussing sensitive topics such as sexual assault. It's important to take care of yourself while listening. Some suggestions are listening while you're in a healthy headspace or knowing who you can reach out to if you become upset. Our 24/7 helpline for crisis calls based out of Central Florida is 407-500-HEAL. By contacting the national hotline at 1-800-656-4673, you can get support and learn about your local resources. There's always someone ready to help. Welcome to the Victim Service Center podcast. Here we sit down with professionals that serve survivors and victims of trauma or those who have experienced violence and have conversations about social issues. This week we are talking about autism and relationships. My name is Emilie Mitchell and I'm the Education Coordinator at the Victim Service Center. With me today I have Dr. Kim Spence. Dr. Spence has served as the coordinator of educational and training programs for the Center for Autism and Related Disabilities, or CARD, at the University of Central Florida since 1999, and as the clinical director of Autism Support Services for Specialized Treatment and Assessment Resources, which is a private forensic practice, since 2017. She has lectured nationally and internationally regarding treatment, specialized therapeutic intervention, and the creation of specialized sexuality education programs for individuals with Autism Spectrum Disorders, or ASD, for over 20 years. Dr. Spence, thank you so much for being here today. We're really excited to have you.
Good morning, Emilie. Thank you for having me. I'm so excited to talk with both of you this morning.
Absolutely. And I also have returning JoEllen Revell. JoEllen is the Victim Service Center Program Director who oversees the Advocacy, Therapy, and Forensic Nursing Department. She is a licensed clinical social worker with over 20 years of experience in clinical and administrative oversight. So JoEllen, thank you for returning. We're happy to have you as well.
It's a pleasure to be here. Glad to be part of this conversation with you, Emilie and Dr. Spence. Thank you for having me.
I'm really excited to have this conversation. And as a really brief introduction, shows like Netflix's original series Atypical are bringing discussions surrounding autism spectrum disorders into the forefront of conversation on social media. So what we are looking to explore in this episode is what exactly is autism? What are some risk factors as it relates to victimization? And what are some challenges those who have autism face when it comes to relationships? So with that in mind, Dr. Spence, I was wondering if you could tell us a little bit about your position and what you do day to day.
Thanks, Emilie. So day to day for me involves advising prosecutors, public defenders, the criminal justice system, law enforcement, families, about people who have autism spectrum disorders who have come into contact with the criminal justice system, either as a victim or as a perpetrator of a crime. And I currently work on cases in my forensic practice involving individuals with autism who have committed homicide, who have committed sexual battery or been the victim of sexual battery or stalking. And I, on a pretty regular basis, provide training for police, which I've done for almost 22 years all over the United States, federal marshals, the FBI, and other law enforcement agencies about what autism spectrum disorders are. I also do a lot of training and work with families and individuals and treatment providers who support individuals with autism spectrum disorders, specifically about how to intervene with people who may have committed a crime, or how to proactively work with individuals who have autism or who are along the autism spectrum about behavior they may be engaging in that could be problematic or in the future might result in them acting out or becoming violent towards other people.
Thank you so much for all of that information. That's really, really helpful to kind of see what you do day to day. And thank you so much for doing all that you do. It's really, really important work. So I guess the first question I'd like to pose to you, Dr. Spence, is what exactly is autism?
Autism is a bio-neurological developmental disability, and what that means is this is a disorder that primarily affects the brain and how the brain is put together. We refer to this as a developmental disability because it's not something that we can see. We know this is a disorder that is present at birth, but typically does not manifest by delays in language, communication, or behavioral issues that may result from an individual not being able to communicate until almost the age of 2 to 3. People who have autism have difficulty with verbal communication and nonverbal communication. And so as part of their profile, spoken language for many people who are along the autism continuum is very difficult. In fact, they have often a delay in processing verbal language. So diagnostically, they have trouble with verbal and nonverbal communication. And we're going to come back to talking about nonverbal communication because this is an area that many individuals really struggle with. And this becomes problematic for the topic we're here today to talk about because they have difficulty interpreting facial expressions and they have difficulty interpreting intentionality of others. These are part of the diagnostic profile as it is articulated in the Diagnostic and Statistical Manual of Mental Health Disorders, or the DSM-5. Additionally, people who have autism have difficulty with leisure activities or engaging in socially appropriate leisure activities. And so sometimes we may see adult individuals engaging in activity that is not safe or interacting with people who may not be safe people to interact with or appropriate people to interact with. And this disorder in particular affects more males than females, as do most neurological disorders. And with autism, it's about a 5-to-1 ratio. And currently in the United States, the prevalence, as reported by the Centers for Disease Control, or the CDC, is 1 in 54. So for every grouping of 54 children, so 0 to 18, at least 54 of them have autism. Now, it's commonly understood that over time, this number has been going down pretty steadily, in particular over the last 5 years. And most epidemiologists and those researching autism understand that probably within the next couple of years, we may go as low as 1 in 40. We're not quite there with the data tracking yet. If anyone is interested, go on to the CDC's website and the Atomic Tracking Project, which has been looking at numbers related to autism for over 20 years. Really great source of information. With respect to adults, who we're going to spend a little more focused time talking about today, currently the prevalence of autism in adults is 1 in 45. So for every grouping of 45 adults, 18 and older, that we may be interacting with, at least one of them has an autism spectrum disorder. And there are many adults out there, unfortunately, who have not been diagnosed for a variety of reasons. I can tell you in our private practice, that's one of the areas we specialize in. And unfortunately, many of the individuals we come into contact with who get accused of a crime, commit a crime, or are engaged in behavior that is inappropriate and or illegal, maybe people who have autism that have not been adequately diagnosed and have not had proper intervention to help them understand appropriate versus inappropriate behavior, how they should be interacting, how to engage in relationships, etc. I want to point out that autism spectrum disorders are not affected by socioeconomic status. It impacts people equally across all races, and it impacts people in all regions in similar ways. Now, in the United States currently, when we look at tracking, there are regions in the US where we see numbers that appear to be higher. For example, in New Jersey, California, here in Florida, and there are different reasons for that. But to make the point that the color of your skin does not drive whether you will have this or not. And for many, many years, anyone who's familiar with the history of autism and autism spectrum disorders, many years ago, it was believed that only white people could have autism. And we know that African Americans, up until very recently, were underrepresented in the overall diagnosis of these types of developmental disorders. So I think it's very important for people to understand that universally, this can happen anywhere with anyone, and that primarily males are going to be affected, and often within a familial unit, we will see neurological issues that run through generational lines. For our purposes today, I want to focus a bit on the difficulty with insight, or what we refer to as theory of mind or executive functioning difficulties. And essentially what this means is that if you are somebody with autism, you have a very difficult time understanding or in real time picking up information socially from people about what they're thinking or feeling. We are, as humans, hardwired to watch the facial expressions of others. We are hardwired to respond to if someone exhibits being in pain or socially demonstrates that they're upset about something. Part of the disorder of autism affects the way the brain responds to, and for individuals who have autism, they're not always picking up on gestures. They're not picking up on intentionality or emotional responses of others. And often, even when they are, it's confusing, or they're not understanding it as a person may be emoting, which is very difficult when it comes to interpersonal relationships, and is very, in particular, difficult when individuals may not understand that somebody's not interested in them, or their advances may not be wanted by a romantic interest. So, knowing these things, we put particular focus on how to intervene with those. And in specific, both at the Center for Autism and Related Disabilities at UCF and statewide, there are actually 7 centers throughout the state. In our private practice and many others, we put a really strong emphasis on how to engage in safe, balanced and healthy relationships, because we know that a lot of individuals who are on this continuum really struggle with all of the dynamic specific things needed to maintain, to even get into good, strong, healthy relationships. I want to also say that about 40% of people with autism do not speak. They are not verbal. And another very large percentage of people are very impaired with their ability to communicate. So even when they have verbal spoken language, they have pretty strong deficits in their ability to communicate how they think about things or what they're feeling. And this is very difficult for many individuals who may not like something that is going on, or may in particular have a strong aversion to something, but may not actually be able to vocalize it to those around them. So essentially, To summarize, these are folks that have difficulty with verbal and nonverbal skills, and these are folks who are very literal in their interpretations. They're very black and white. So they're going to take things at face value. They're often going to misunderstand communications because the way they're interpreting things verbally is often how we might kind of mechanically understand things, but not emotionally what a person may be conveying.
You kind of started going into it a little bit, and I think a lot of times when we talk about autism, we talk about spectrum. So you mentioned that 40% of those with autism don't speak. Does that kind of talk about the spectrum of, is it like a severity? Can you explain a little bit about what it means when we talk about the autism spectrum?
Absolutely, that's a great question. So in previous years, autism was first identified in the DSM in 1980. In previous years, we have gone through many iterations of what the actual diagnosis of autism looks like. If we hearken back to the DSM-4, we had several different specific subcategories that were under a large heading called pervasive developmental disorders, or PDD. And at that time, so from 1994 until 2013, those 5 subcategories were pervasive developmental disorders not otherwise specified, Asperger's syndrome or disorder, autism, and then 2 others that kind of fell out because they're genetic issues, which are Rett's disorder and childhood disintegrative disorder. But the big 3, autism, Asperger's, and PDD-NOS, were referred to along a continuum, and they each had individually specific criteria for diagnosis. What happened over the years, people began referring to a, quote, spectrum or continuum to make this reference that there were 3 things you had to demonstrate pervasive problems with, which were communication, which we've discussed, verbal and nonverbal communication difficulties, specific social problems, problems with reciprocity, meaning interacting with others, picking up on social cues from others. And the last criteria were limited interest areas, engaging in repetitive behaviors or mannerisms. And over time, the reference became you were along a, quote, continuum, because you demonstrated, or for a diagnosis, would have to demonstrate specific behaviors, and think about these as a list, almost like a menu, and a diagnostician, based on testing and interaction with an individual, would say, yes, there are enough check marks in each of these boxes to say this person meets the criteria. When the DSM was revised in 2013, those 3 categories I mentioned under the previous pervasive developmental disorders heading, they were basically collapsed. So people still make references to Asperger's syndrome. However, that is not a diagnostic option any longer as of 2013. Though people still refer to it, I still work with adults who say that's my diagnosis, and they're perfectly fine, have no issue with that. But the references to continuum came as a result of having these different box options, essentially. And when they were all put together, currently, when we look at diagnostics or we diagnose an individual, they are diagnosed with autism spectrum disorder, which means they have specific issues in social and communication difficulties. And in a big, large category that refers to idiosyncratic behavior, very highly fixed interests, unusual repetitive mannerisms or movements. And I want to make the point that along this continuum, essentially, no 2 people are alike. I've been working with people with autism spectrum disorders since the late 80s. And I've met thousands and thousands of people with autism. And though they have similar characteristics, they are different individually and in the way they present their particular set of symptomatology. So often when we make these references, we're saying basically people are along this very large continuum because they present a little differently. And though they have autism in common, the way that it presents for each individual is very different based on their personality, their skill level, and sometimes their intellectual capability.
That makes a lot of sense. And that's a really important point to always make when we talk about any kind of mental disability or disorder, that just because someone has depression doesn't mean people with depression are the same people or experience it the same way. So I really appreciate you breaking that down. JoEllen, I feel like we definitely need to get you into this conversation too. So I apologize. But
I'm loving hearing this.
Yes.
This is such great information, so no need to apologize.
Yeah, I'm learning a lot too. But I wanted to throw you a question as well, JoEllen. Does the Victim Service Center assist persons with autism?
So that is a really good question. And what I would say is when it comes to particular services, because we are the only rape crisis center in Orange, Osceola, and Seminole counties, for particular services, the answer is yes. Because if an individual reaches out to us on our helpline and they want to talk, we're going to answer and we're going to provide a service. If someone has been a victim of sexual violence, whether it's a male or a female, and they're over the age of 12 years old, and they need a forensic exam following that sexual assault, it will be our center who provides that exam. And the sexual assault nurse examiner and the sexual assault victim advocate will be present to assist the individual. We also do have ongoing counseling, advocacy, criminal justice navigation services that advocates perform. And I think when it starts to get after like the acute immediate service delivery, we really need to make an assessment into the appropriateness of continuing to work or exclusively working with an individual. And that's really especially important in when we provide therapy services, because as Dr. Spence mentions, every individual with autism is different and unique. And some present with very high IQs and the ability to verbalize. And there is a potential that they can participate in ongoing therapy services and do well in those services. So the answer would be yes, we do. But if we were made aware of a diagnosis, that would be a special consideration, just like any disability would. If somebody was blind, deaf, had a diagnosis that we needed to consider, we would make the appropriate accommodations or referrals to make sure they're served in the best manner that they can be served. But we do, and we have worked with individuals, especially in the acute cases. And then we look at every individual case to see whether or not continued services make the best sense for them.
Got it. Yeah, I think it's always really important to highlight that the VSC does individualized services, that we really cater it to the individual. And so anyone with autism, it would be no different. So that's always really important to highlight. So thank you so much. Dr. Spence, we were kind of going over it a little bit, and I'm really excited to jump into the meat of this conversation really, which is, what are some of the biggest relationship challenges faced by persons with autism?
That's a great question, and I would start this conversation by saying individuals who are on the spectrum in general, this doesn't mean every single person, but in general, they're very socially isolated. They very commonly have very few friends and very few people outside of their family or school situation that they're interacting with. And this particular piece of information puts people at risk for a variety of reasons. But this idea and understanding about the social isolation, if you don't have a reliable peer network, you're going to be at risk in some ways. And I say that because a lot of the information that people come to possess, in particular as people are growing up and going to school, going on to college, comes to them as a result of being part of a social group and hearing about things that happen, discussing things with their male, female, however, friends. And so individuals who are on the spectrum don't have this same reliable peer network maybe to bounce things off of. So most of us, when we are getting into a relationship or we're interacting with somebody or we're having a difficult time, most of us have friends, close friends, people we have known that we understand to be safe people to seek guidance and knowledge from. And most people along the spectrum, their parents may be the only people, if they're even able to discuss relationships and such with them. So I perceive that as something that's really, really challenging. Additionally, with respect to relationships, it's difficult for most people on the spectrum to interpret or intuit what a person may be communicating. For example, one of the young men I have worked with for a very long time, he very much wanted to have a girlfriend. He very much wanted to go on a date. And what was happening with him pretty regularly, he was going into particular establishments or going where other young people in their young 20s were, and he would just begin speaking to women that he was attracted to, and he would introduce himself and in general was trying to be appropriate. However, he did not understand the face that young women were making, looking at him like, oh my gosh, why are you still talking to me? Or they were eye rolling, or they were giving him really clear nonverbal cues or indications that they were not interested in him. He was creeping them out, and that they were a little bit scared probably in some instances. And on multiple occasions, law enforcement were called, or people that were in the area were asked to intervene because this particular individual did not understand the way he was coming across to young women who he was very interested in. He was very attracted to them. He would want to, get their number, and he would follow them around. And in some instances, in a restaurant or in a store, he would follow these young women around and out into the parking lot, not understanding that for most of us, that's scary. And a person who's not known to us, that's not appropriate behavior, and that's scary behavior. And so not understanding how another person might be perceiving your actions is a really difficult thing. And for the adults and the teenagers that I have worked with over the years, one of the things we put a lot of focus is on checking in with others and practicing specifically when someone's arms are folded, when someone's looking away from you, when someone's not trying to maintain eye contact with you, that probably means they're not interested in. And so we have to practice that, and we review that very specifically as a part of intervention. There's a lot of difficulty with making new friendships or having the skills specifically to engage in appropriate romantic relationships, whatever that may look like for an individual. So understanding attributes of somebody you want to be with. And a lot of the people I have worked with for the last 25 years, the primary source of information they have are their parents. And for some individuals, that's not a bad thing, but for a lot of other individuals, it's not a great barometer of how I should think about entering into a relationship, what I might accept as behavior that's okay or safe. And it's concerning that they just don't have a lot of information. And in some instances, a lot of individuals on the spectrum, they've not had any sexuality education. There's a huge body of literature that helps us understand that when you're in a special program, or when you're somebody who's been identified maybe having an IEP, that for years and years and years, they were actually not given the same kind of sexuality education their peers were. So here we have people that have not had maybe anyone talk to them about, this is going to date me, but the birds and the bees. So That's not been discussed. It's not being discussed in their familial unit, and they don't have a circle of friends or people or acquaintances around them to understand kind of, here's how I flirt with someone. Here's an acceptable way of flirting. Here's an acceptable way of seeking out a friendship or a romantic friendship. And that's incredibly difficult.
It sounds like there's these social things that we take maybe that we're used to understanding as people who do not suffer from or have autism spectrum disorders. And it sounds like it's almost like an extra training. It has to be a little more specific. And I like how you were talking about the body language, specifically like if someone's crossing their arms, that might mean this thing. So it sounds like it can be really difficult to engage in relationships without that kind of training that you were talking about, without those specific examples and understanding of things like sex, things like flirting, and things like communication. I think also I'd like to highlight that I think sex education is there's a lack thereof in general, but I can see why it would be even more important for someone who has autism spectrum disorders for them as well. So I really appreciate you breaking that down.
Absolutely. And I just wanted to say to that end, so a lot of the people I work with and I have worked with over time, in addition to the things that were just mentioned, they also may engage in behaviors that have been acceptable within their familial unit or maybe even within a school program they were in. For example, hugging people, so going up to complete strangers and hugging them, or going up to complete strangers and kissing them. I've worked with several adults who, as part of their greeting, would walk up to somebody they wanted to interact with, and they would introduce themselves, and then they would reach and grab the person's hand and kiss their hand, which in probably medieval times was delightful, but in this day and age, this is dangerous. And in many instances, I work with teenagers and young adults who there's behavior they've engaged in for a long period of time, and their family may not have perceived it as something that could potentially become dangerous or might be perceived by others. And then they become adults, and then they age out of school and go into the community. I recently had a situation at the University of Central Florida, actually, where the campus police contacted me because there was an individual on the campus who was basically, when students, he was in one location, and as students were passing him, he was randomly charging up to them and hugging them. And he basically was wanting to interact with them, but that was how he was leading into interacting with them. And this is an individual I want to point out who completely verbal, attending the university, somebody whose intellectual capability is not affected. However, this is a clear deficit in his social capability and understanding of acceptable versus not acceptable. And this is a guy with a very high IQ. So the police did a fantastic job. Love the UCF Police Department, did a fantastic job of saying, hey, we recognize something's going on here. He doesn't seem to be wanting to try to hurt anybody. And that's thankfully an instance where it didn't go any further. But I've worked on plenty of other cases where that behavior left unabated can go down a very bad road.
I just wanted to add in there some points to kind of piggyback off the conversation. I completely agree with the concept of, what you learn or what an individual with autism learns is what they believe is appropriate. And sometimes I think we have individuals who are getting a lot of information from TV, movies, repetitive television shows, and whatever relational issues are arising on those shows would potentially dictate what someone with autism thinks is appropriate and allowable. So that is something to be aware of. When you asked me earlier, Emilie, in terms of do we assist people, we do, but that's for intervention. But as it relates to your role with prevention, and kind of healthy relationships, we don't have an explicit training for those with autism. Our training is much more generalized. So it is a curious question of, is there more that we can do or adapt what we do to assist in providing a general overview of healthy relationships in a way that might be a little bit easier for someone or groups with autism to understand and receive. And it may be through the use of more repetitive actions, more role plays, things of that nature, rather than just kind of verbal instruction.
Yeah, absolutely. I think that's really important to bring up, that we can definitely learn more and cater specifically to different populations, including those who have autism spectrum disorder. So that's a really excellent point. And kind of to switch gears a little bit here, JoEllen, I wanted to ask you a little bit about, the frequency of the autism diagnosis.
So I know Dr. Spence mentioned it, but I appreciate all the context that she's offered. The numbers that I have are the same numbers that she referenced in terms of youth being 1 in 54 and adults being 1 in 45. And when you think about the number of victims that we see annually at the agency, which whether it's one-time or ongoing services in the thousands, it's an absolute that we've had individuals who are autistic who are in need of care and service. The thing about it is that not everyone is aware of their diagnosis, and sometimes you have autism and there are additional diagnoses that you have, and which ones are kind of presenting or more heightened. Those things are things that we experience here at the agency as well. Did you want to mention anything else, Dr. Spence, in terms of frequency from your data?
JoEllen, that you're right on point with that, and I love that you're giving numbers in the context of the people that you all are serving. And to piggyback on what you said, I want to touch on comorbidity. This idea about comorbidity is incredibly important, and people need to understand that when an individual has autism, whether they know they do or they don't, which is also a fantastic point, JoEllen, they are more likely to have a comorbidity of another mental health disorder. Most often, this comorbidity is going to be depression. Secondarily, it's going to be OCD or another anxiety-related kind of issue. And I think it's critically important when working with individuals to understand what things are manifesting for that individual, because if I'm making recommendations only on the idea that a person has autism, I'm not going to treat or be helping them or intervening to help them with the depression or other co-occurring disorders. So I think it's really important to keep in mind this idea that more commonly than not, individuals who are on the spectrum have co-occurring mental health issues, and those may supersede the need for intervention versus the way we come at it only specifically focused on their autism. So I'm really glad that you mentioned that, JoEllen.
Absolutely. Thank you for adding to that conversation point.
Perfect. And yeah, I wanted to kind of go back to consent actually a little bit as well, because I think that that's really important to highlight. And like JoEllen mentioned, in our trainings for healthy relationships, that is definitely one of the main things that we focus on. And with that being said, can a person with autism consent to an intimate relationship?
That is a great question, and one that I wish more treatment providers were focusing on in terms of treatment and prevention. Individuals often with autism or other disabling conditions have been systematically taught to go with people that are not known people to them and to accept touch or someone being in their space. And so regarding consent means I freely give it. I make a choice that this is something I'm okay with. And for many individuals I work with, this is a foreign concept, unfortunately. This is something where if they get into a relationship or with someone who's predatory or intent on victimizing them, they are more at risk because they might just kind of go along with whatever is happening. They might not, and often do not, speak up for themselves because they are unaware that they have a say in the matter. They are unaware because they've spent 18, 20, 25, 30 years doing what other people have told them to do because that's the quote unquote right thing to do. And again, I want to be clear. I love my families. I'm an educator myself. This is not said or intended to slam anybody. It's a statement of fact. And when I'm working with families or I'm providing training, I say to people, you need to look within the bubble, because often families and providers, we try to protect people with disabilities under this bubble. And if I keep you in this bubble and I don't let you out into the general public, you're going to be more safe. And in fact, you're less safe in that bubble. There are people in that bubble who become providers to have access to people who are not verbal, who have a disability, who I can easily victimize.
All fantastic points. Thank you so much for shedding light on that. I think when you were talking, I was thinking about children as well in general, where they are also taught at a young age to, you have to go hug this person because they're part of your family, or that kind of thinking of not understanding that you have a right to your body and you have a right to consent and withdraw consent. And so I can see why the complication of go with this speech therapist, go with this behavioral therapist can really complicate that conversation of consent for those with autism spectrum disorders.
Can I also add to that? I think that's a very great point that Dr. Spence made in terms of this concept of going to this provider. And as a parent of someone with autism, I can say often providers change so frequently. And I'm not sure why that is, and I've experienced it as a parent, that it's, there's a new therapist, there's a new occupational therapist. Okay, we'll just get to know this person. And that idea that you're just kind of allowing your child with someone that is completely brand new to you, but you need a service, it happens frequently. And I wonder what the child themselves is thinking. And I'm sure it's not comfortable. I know it's not comfortable, but it is exhibiting actions that could let a youth with autism think this is any new person could be the person that I have to just listen to. And that's an unfortunate consequence.
That's a great point. And Emilie, I just wanted to add to this idea about consent, and JoEllen just did a fantastic job of articulating this. So many young people or adults, even in a familial unit, they don't want to hug their grandma, their grandpa, their aunt. And actually there are intervention programs, behavior analysts, educators, or treatment providers, and kind of forcing this issue. So I think just going back to that idea that they may have been systematically taught and not even have an idea. And the other just point I want to bring up, so for a lot of young men who may engage inappropriately or victimize, don't understand that silence is not consent. Silence because the person isn't saying anything, or silence and you continue with a behavior, that is not consent. And I think that's a very important idea and concept. And I know the young men, the teens we work with, and young women, is checking in. You have to check in. And because you have sexual intercourse, because you hug someone, because you do that one time in any kind of relationship, is not consent that you are okay with that happening again. And how the importance of having an open dialogue and having a communication regarding what you're okay with and what you're not okay with, what you want and don't want.
Absolutely. In our trainings too, I always like to bring up that consent is a conversation. It can be withdrawn at any time. And it seems like what you're able to do is kind of bring that to light, and checking in is so, so important always. So I love that you brought that up too. So I really appreciate that, Dr. Spence. You talked a little bit about, risk factors of being victimized. And now that we know a lot more about autism spectrum disorder, I can see exactly why that should be a conversation to have. So, JoEllen, I wanted to ask, what are the risk factors those with a disability such as autism face to being victimized?
Well, I think that this could be a very long conversation, but I think the clear point is, being victimized can start very young with that concept of being a high target for bullying. So that kind of peer victimization, if you will. If you are an individual who's autistic and you are struggling to socialize, and there is a group of children, and with typical form, children tend to tease or small groups and cliques. And so that person with autism is much more likely to be on the receiving end of bullying. There was a study that I was reading, and as it relates to adults who have been victimized, 78% of the respondents who have autism, compared to only 47% of the ones who didn't, indicated that they have experienced at least one occurrence of sexual violence against them. And it was explained with, questions that were more specific so that they understood about like inappropriate touch after saying no. So the data indicates that there is more prevalence, and that's for individuals that, responded to that survey. But I can't say if it's truly indicative to the whole population, but it certainly was indicative to those individuals that the rate of victimization was higher. I think that there's just more risk for the individual to be a target. We see people be targeted, grooming for human trafficking, grooming for sexual violence within a family system. So there are so many individuals that are out there and that have negative intentions and want to take advantage. And as someone with autism who maybe can't verbalize or can't completely articulate or has not established an understanding of boundaries, could be at seriously heightened risk of being a victim.
That makes a lot of sense. Absolutely. Dr. Spence, did you have something you wanted to jump in on that, or?
I appreciate JoEllen giving the citation or referencing the study, and I want to say that there is a large body of evidence that suggests that having autism, having in general any developmental disability, so intellectual impairment is a developmental disability, autism a developmental disability. This has been very well studied for the past 20, 25 years now, and the data is conclusive that having any kind of these disorders or any one of these disorders puts you at significant risk. There are two studies that suggest that 9 out of 10 women with developmental disabilities will be sexually assaulted in their lifetime. That is a really dramatic number and gives me goosebumps every single time I say it. And there are studies looking specifically at autism. There's one I was actually reviewing with some folks the other day. There's a gal by the name of Rosemary Hughes, who's out of the University of Montana. And she's doing some fantastic work in creating programs and creating curriculum for prevention. So their group, and they work within a consortium, is working within a group to pilot curricula for individuals with autism and other developmental disabilities, and then studying specifically how effective that curriculum is. And one of the recent studies, she actually cited that she had 170 adults and 60% reported abuse, either emotional, physical, or sexual. And, as JoEllen mentioned, I could pretty much go on for the entire podcast about the incidence rates of these things occurring. So to say to families, providers, and to everyone involved, this is a really dramatic problem that's happening, and unfortunately is still not something terribly openly discussed in many places. And in 2018, NPR did a huge report that was well broadcast, talking about the increased incidences of sexual assault, and they basically culled data from the Department of Justice for I think the last 25 years. So these are really important numbers to get out there. It's obviously these are not going to prevent people from getting victimized. However, I think we need to put a bigger focus on helping families, helping providers, working with individuals so that they understand how to keep themselves safe and how to not get engaged into these situations that could put them at really grave risk.
Actually, that kind of leads to my final question here. But before we get into that, I wanted to give some background information for everyone listening. So first, JoEllen, I wanted to see if you would be able to describe the role of a rape crisis center victim advocate.
Absolutely. So in the state of Florida, there are rape crisis centers that are specific to each county. So being that we are in Central Florida and there is a 3-county area that we serve, we are the certified rape crisis center for Orange and Osceola County for those who are 12 and older, and in Seminole County for those who are 18 and older. And so the first role that a victim advocate at a rape crisis center has is that they answer the helpline. So they are an immediate conduit for individuals who are reaching out for help. And at the Victim Service Center, we do require that our advocates have a master's degree in order to work at our agency. So those individuals who work here as victim advocates, we often refer to them as sexual assault victim advocate, because the additional roles that they have is they accompany victims to the rape crisis center for a forensic exam following a sexual assault, and they provide the immediate support and ongoing support for a victim of sexual violence. Now, at the Victim Service Center, we work with all victims of crime, but because we are the Rape Crisis Center, many people in the community know us primarily for that role. And then the victim advocate can do ongoing work with a victim depending if they report the crime to law enforcement or not, if they want to pursue criminal charges or civil charges, if they just want to work on their healing and they want to learn some coping techniques to deal with the victimization. You know, sometimes we work with victims who have repeated victimization, and so they need to deal with the recent victimization and something that might have happened to them as a child. And sometimes they need some additional support and ongoing therapeutic interventions, which our therapy department would do. So as it relates to the term victim advocate, I do want to share that that is a term that is used differently in other agencies. But at the Victim Service Center, it is a master's level counselor that accompanies, assists, and walks through the entire process post-victimization with an individual. I hope that was useful.
Yeah, absolutely. Thank you so much for breaking that down. I think that that was a wonderful overview of exactly what victim advocates do here at the VSC. And with that being said, with that clarity, Dr. Spence, I had a final question for you for, what are some suggestions that you would give a victim advocate who needs to help a person with autism who has been victimized?
I think first and foremost, to keep in mind, as we've discussed, that all people that have autism are going to be different. I think it's very important to have a cursory understanding of what autism is. There are many places here in the Central Florida area, throughout the state of Florida that offer free and engaging programs to give overviews about autism. And the University of Central Florida's CARD, there are, as I mentioned, 7 centers throughout the state. So geographically, every single district throughout the state of Florida is supported by a CARD center in their geographical area. CARD is a technical assistance center serving people with autism spectrum disorders from birth to death. So any age, and all the CARD centers provide free training, free overview training, behavioral training, and I would urge anyone, any of the victim advocates to at least familiarize themselves, and obviously not to at the level maybe where I'm talking about as a diagnostician or intervention, but just to have some familiarity, because understanding how the presentation may look when someone has been affected by trauma, typically their responses may look very different than their neurotypical peers. So I think that's really important to have a general understanding. And I also think it's critical to keep in mind that interacting with many individuals, regardless of how they're presenting, and by that I mean they can be highly verbal, they probably are going to need more time to process any information that's being provided. And for most individuals along the continuum, they will need something visually to support what's being said, taught, or however you may be intervening, and they may need to hear it several times. I think in general, most people need to hear things a few times before it sinks in. And what we know about trauma and people that have been sexually assaulted or traumatized, they're often not available to hear incoming information. And when we think about people with autism, on the best day, they have a difficult time taking in information. So to keep in mind how we're using language, and to check in with that individual to make sure that they're understanding specifically what's being said, and to get feedback from them. What did I just say to you? What does that mean to you? And asking them very specifically directed questions to check for comprehension. We talked about the comorbid mental health issues. And I just want to point out, most people listening probably know that currently suicide is the second leading cause of death in the United States. So for people 10 to 34, this is the second leading cause of death. And what I want people to know is that individuals that have autism, in particular that are in what many refer to as the higher functioning range of autism, they're about 20 times more likely to commit suicide than their neurotypical peers. So we're talking about really big numbers. And we all understand that any victim is going to be at risk, obviously, and that goes without saying. But I just want to put that comorbid condition issue back out there for everyone to understand. The numbers are huge, and the numbers are very clear, and to keep that in mind when we're working with someone who may not be able to articulate suicidal ideation. And I know the victim advocates have a very set way of intervening, and they're highly trained folks, but just to keep that in mind when we're interacting. Lastly, I want to just recommend very specifically CBT, and most people are very listening to this well familiar with CBT, dialectical behavioral therapy, DBT. What we currently know about people who have been victimized, who have autism, or people receiving treatment, one of the best targeted treatments means that they're getting CBT, a combination of that, and DBT, in addition to very targeted social skills instruction. And by that I mean, maybe in their safety plan, we are clearly articulating certain behaviors they're going to avoid, or places they're going to avoid, and they're going to need a more substantial documentation or a more substantial intervention as it relates to, if these things happen again, this is what you need to do. And I want to bring up, I have several young women I have worked with, and one in particular, she has been date raped several times. And each time she has a large team of people supporting her. And each time this has happened, there's been explanations, there's been intervention, but there hasn't been the component of teaching her how to not get into that situation again. And just to articulate this idea that the safety plan obviously is going to look different for different victims depending on the situation or the perpetrator, etc. But when we're dealing with young men or women or any male or female who has autism, to keep in mind that how specific it needs to be. Very clearly saying which situations we don't get into, we can't get into again, that may increase risk for individuals.
That's such a great point. I really appreciate those suggestions, and we will definitely have conversations internally to maybe get a fact sheet together and make sure that our staff are well aware, and also more importantly to make sure our partner agencies are aware, because we do receive referrals from law enforcement and from hospitals, and so if they're already interacting with a victim, there's the believing factor is important, but also kind of the approach to the individual needs to be done in a way that is respectful, specific, and I really appreciate the idea of the repeating the information. So thank you, Dr. Spence, for that. I look forward to actually having an internal conversation with our team about ways we can improve our practice.
I appreciate the dialogue, and I appreciate the work that you all are doing, and all victim advocates are doing. And it's amazing to have this dialogue and just having this conversation with you all as it relates specifically to supporting victims in general is really making me think even more specifically about our practice and how we're relating and conveying information. And I was just thinking when JoEllen was speaking that often people interpret, when I'm saying detailed plan and I'm saying reviewing it, what I want to be clear, I'm not saying is to basically look at an individual and say the same thing 10 times really slowly. That's not necessarily the reference I'm making, but to make the point that going back and checking with that person to understand their level of understanding of the concepts or the constructs you may be talking about, to make sure that they get it. And more importantly, within the sphere of their social network, their family or whomever, that other people understand specifically the safety plan and can help that individual, remind them what that means, or point out when specific things happen whereby the victim advocate obviously can't follow the person 24/7, but it's very important in the learning of people who have autism to have things in vivo pointed out. Okay, so I just saw this happen. Remember, on your safety plan, it says, I'm not going to communicate. I'm not going to receive text messages or people who have perpetrated. I'm not going to send people I don't know. So that specificity and helping the whole network of people surrounding that person to understand clearly things that we don't want to see again, and how to help that person understand how not to get in the same situation, whether they're a victim or a perpetrator.
I think that is so much great information that you shared with us, Dr. Spence. And again, thank you so much for being here and bringing to light this issue that is really important to talk about. Obviously, there's even more to talk about, and we're happy to bring you on actually another podcast episode later on, so we can continue the conversation. But with that in mind, I do think that this is kind of a nice place to kind of sign off here. But before I do, is there anything you, JoEllen, or you, Dr. Spence, that you'd like to talk about before we sign off?
I'm going to go first, and I just really want to extend a huge thank you to Dr. Spence for being so invested in sharing information with the Victim Service Center and obviously with the audience that we can serve. And I think there is so much more we can do to improve practice, and I look forward to some future next steps to making sure that victims are served in the way that they should be, that is appropriate, and that our agency is able to assist in a manner that is necessary for victims. So thank you again.
In conclusion, I want to reiterate my gratitude to you, Emilie, and to JoEllen, and to all of the victim advocates out there supporting survivors of sexual assault and violence. Your work is so incredibly important and critically necessary, especially in these times. I want to encourage anyone listening to this podcast to reach out to your local autism experts. Here in the Central Florida area, the University of Central Florida Center for Autism and Related Disabilities, and all across the state of Florida, other CARD centers supporting their communities or other community-based agencies who provide free and meaningful training. I also want to remind people that every person with autism is different. Having autism is like having several other kinds of conditions, and there are no two people alike. So if I have autism and my friend has autism, we'll have some similarities. However, the way I perceive things, the way I might accept advice or assistance is going to look differently. So I just want to really emphasize the point that it is a spectrum, and the way that people present is very different in all aspects. And a lot of that has to do with the familial units that we come from, our friends, and sometimes other kinds of comorbidity or issues we might be having. And I also want to encourage people who are providing crisis intervention, therapeutic supports, or ongoing therapy to please keep in mind how important visually supported aids can be to individuals who have autism. These can be in written form, these can be a visual script, these can be static pictures, video. These are all very important resources to use when we're interacting, and one of the ways we help to ensure that the individual is understanding what we're saying to them or how we're providing them intervention, and we check specifically that they are able to accept and or embrace their therapy, crisis intervention, or anything that you all might be providing at your center. Thank you again, and I've really enjoyed having this very important conversation today.
Absolutely. And I think that's a wonderful place to finish up here. So I want to just thank the listener for listening to the Victim Service Center podcast. The VSC is a nonprofit organization that provides free, confidential counseling services for victims of any kind of trauma in Central Florida. And to learn more about our services, please visit victimservicecenter.org. And to everyone listening, healing is not linear and you're not alone. And I just want to thank you, JoEllen, and you, Dr. Spence, once again for joining me today.
Thank you.
Thank you for having me.